All right.
You're all good.
Perfect. Thank you. I haven't looked back. Is anyone watching them later, going back and seeing how we do? It's nice to see everybody. So welcome. Tony is going to be joining us in a little bit. So I think that we can just kind of open up to welcoming all of you back for yet another one of our meetings that seem to be moving in the right direction. And it's so exciting. One of the things that I was hoping we could think about discussing today was considering finding a time for us to all be in the same room physically, which is ironic that that is where what you have come to do, but really trying to find an opportunity for us to think about a way and a space that we could all convene and really think about making it a work meeting, not just a social gathering of like minds or a networking event, but truly do a work meeting as we move towards getting all of this together for our deadline. So I don't know how people feel about that. I was thinking it might be kind of inspiring. Well, perhaps inspiring to me, but I thought it might be kind of inspiring if you all came to the Children's Hospital and we worked in one of the conference rooms here just so that people can kind of see where we are and some of the work that we're doing here, but also just really be inspired by being surrounded by the children we're doing this for. So if people are open to that, we are opening our new tower next month, and I was going to look for
Wow.
a date in January where we could utilize one of the new conference rooms and bring people in. And I don't know if you'll be back in the area, but we'd love for you to join us. Maybe not I'm not commenting on the airline travel since I'm flying to San Diego next week and cannot drive alternatively. So we're going to hope I get there for my sister's surgery.
Oh, geez.
But I do, it would be lovely to have you join us and think about that. How does that resonate with people in terms of next steps and kind of a January kind of thought process?
And one thing to add, Dr. Moss, is we have 2 days in January, January 7th, which is our regular scheduled group meeting, and the 21st.
So
So,
yeah, and I wonder if the 21st would be, I wonder if we could shoot for the 21st and see, or the 7th. I can look and see what our conference space availability is for that day. I
mhm.
wanted to see how that resonated with people, if they would be willing. We thought about an afternoon working meeting so that people that have I'm in myself hospital commitments in the morning. It makes it easier if we do something in the afternoon. How does that sound to all of you? Would you be up for something like that? I just feel like we could probably I think our volume of output from that meeting would be greater if we were in person.
And we could also use that time, our report is due February 6th. So it's about a week and a half, basically, sort of 2 weeks to go before, just to refine everything we're thinking about. So that would be helpful.
All right, so we will look at those two dates and see if one of those could work and if we were able to host that here. So I will go ahead and be in charge of relaying that information back to you all and getting you that information. So I think I know we have ongoing things that we can continue to talk about. We did have a full group obviously meeting last time. We have, a nice scripted. I don't know if everyone saw the Champion Care Action Team PowerPoint. As yet, we can walk through that or wait for Tony Ann to join us. But I wanted to see if anyone had any questions or thought that you wanted to address during today's meeting, because I do think as we think about this, we really need to think about what does it look like? What is our output going to look like? And what are the goals that we hope to achieve? Because our timeline is going to get very shortened by the holidays that are upon us. Right? You hit a point in November when all of a sudden it's January 1st. And somehow there's a month called December that comes between.
And you haven't done any of your holiday shopping either. So,
I don't know what happens. The calendar just evaporates in December somehow.
yeah.
So open thoughts before we start to look at today's slides. Barbara, I think there was some really nice response to your conversation last week. I think it's really important for people to understand what MOLST is and can do. And I think there's an assumption of general understanding that is not there. To be honest, I don't think many people that fully understand the benefit of a Molst and I think there's a lot of quite sadly, I always hesitate on things that are live streamed, but sadly, I think there's a lot of physicians that don't know what Molst can do for their patients and don't utilize Molst in the way it's meant to be.
Mhm.
And so I think that that was a really helpful
Right.
conversation. Well,
We did have our monthly meeting yesterday, and I did bring up the parent, I think, is it Ann Caramello, or I wrote it down, her comments regarding where a suggested place where a most form should be stored and how it is different in a pediatric case. And I think the overwhelming group just kind of scratched their heads and said, why didn't we even think of that? That was, we should have thought of that. So we will be contemplating in the policies and procedures what we will recommend for that moving forward. So thank you.
well, and I think if I might add, I have a pediatric patient that's being managed by an adult group for, currently, and has an adult nurse that isn't familiar. And so a Molst was placed, and then he went on a Make-A-Wish and a rush trip to Disney, and they didn't give them any paperwork to take with them, right? And so they went on their trip without the paperwork in hand, and that is obviously not what we want. We want to make sure, but as the nurse said to me, I don't know that I've ever placed a Molst and had anyone travel, right? Just in the hospice setting. Often when those Molsts are set, you're in the home with them, and there's no question they're not going anywhere. But with this little man, he's traveling everywhere, Monster Jam, you name it. He's living his best life. And I just was like, we just need to make sure that we're clear how that paperwork travels with him so that mom doesn't have to go through all the questions and can present that information. So I forget that even people that do hospice and are so versed in hospice don't always think about how the implications of a Molst are utilized with children. Right, there really can't be enough copies in enough places. I mean, obviously, we don't want people traumatized by looking at them, but there can't be enough conversation of how to enact that should things happen in school, right? All the different places that children travel, even as they move towards the end of their lives. Children are oftentimes in many places, and just making sure that those important documents are available to those who are caring for them is probably a bigger topic than we may have thought it would be. Any other thoughts or comments?
I just had a question for Barbara. In terms of all the things around Molst, are there really things that stand out to you that we should know as a group as it relates to this? I mean, any like serious key takeaways that we should be, should be top of mind for us?
I think just the presence of a most, as Dr. Moss had indicated, there are still many physicians that are unfamiliar with most. Two of the Most Advisory Council members and I went to the APRN conference this week, and we had a group of 100 people. And while many of them had awareness about most, many did not. And the overwhelming comment is that their colleagues also don't have an awareness around most. So the group, the advisory council, one of our strategic plans for 2026 is to increase awareness around most among all care providers and consumers included. As I noted last week, we are developing a consumer FAQ and a consumer training. So I think it's important. I think the key takeaway is everyone should have an awareness about most. And to your point, Dr. Moss, we are also in our narrative at our new slide training deck. We are doing a little more narrative about how even adults should contemplate. We have individuals who are snowbirds who live with a serious life-limiting illness or have a chronic disease who qualify, are eligible, and we're encouraging them. Be ready, be prepared when you travel.
Right. And make sure, these conversations, it's an interesting thing. We were querying how many young adults we take care of here, right? Above the 18 age. And there's quite a few. Certainly in my world of oncology, we take care of a large number of young adults. And when the patients come in, they are given kind of your right to know packet, which I don't know if any of you are familiar with the right to know packet, but I think yes, I see you shaking your head. It's not, it's really fills a JCO requirement, and it fills, it checks the box, but it's not, this packet has like a healthcare representative form. It has like a 20-page packet that when you are an adult admitted to a pediatric hospital that you get. I love that they give them something. However, it's not, it's not the best tool necessarily. And in that packet, there is no mention of the MOLST and what the opportunity for a MOLST is. And so I was realizing that we really need to, literally in the last week, have been thinking so much about the fact that I'm so committed to young adults in receiving care in a pediatric hospital when their diseases benefit. So, right, we know that an oncology patient that receives a pediatric protocol will statistically do better. And so we welcome that. But we also need to think about the 29-year-old that just had a baby and making sure that we know who is making decisions and just helping with those pieces. And the packet that they receive does not have any reference to a MOLST. So anyway, Barbara, I'm on that, and we'll be continuing to look at the way we really provide that information to people. I don't know if you in Washington do anything, if you know of any way that they do it differently for the young adults coming in the hospital.
It's very, I would say it really depends on the institution and the protocol that they have. It's pretty widely accepted within the Medicaid programs that if you have a pediatric illness or something that was diagnosed as pediatric and it's carried into young adulthood, that qualifies you to still have the same amount of benefit when it comes to even like private duty nursing hours or hospice or concurrent care, et cetera. And so the hospitals have mirrored that to a degree, but what we find is that when we get to the 22 age, even honestly 21 still, we do start to see hesitancy with some of the more critical care units wanting to accept them. And so it's not so much the pushback from the oncology unit or even the step down unit. It's usually the PICU or the PCICU that are really starting to have that question of like, but what can we do for them? Because now they're an adult, we don't feel comfortable. This is a bigger body than we're usually taking care of. So it depends on the institution, and honestly, even within that, it's the unit and their agreeability to continue that. From a MOLST standpoint or a post standpoint, there's really a big barrier and a separation, and really to your point, Barbara, that we've noticed that providers and people that are working inpatient, they don't necessarily have that education or awareness of what's available for a community-based DNR or limited resuscitation order. So I know our palliative care teams have been doing a really great job at trying to educate that and try to obtain a post or MOLST before discharge so that they're going home with that. And that's been a really great bridge to have. But I think even though we've made a lot of great steps as far as expanding care for pediatric patients that are going into young adulthood, there's still nothing that's consistent across the board. And there's nothing that's really in place that protects that. It's more of a best practice protection, if that makes sense.
It totally makes sense. And I think that it's a target group that we need to think about how we approach more consistently, and also with the fairness of understanding that the assumption that the team will know how to handle all of those things in a pediatric community is an unfair assumption, right? So what it benefits is if I help you, the young 27-year-old nurse that I met with today, if I help you figure out and even put in documented who makes your decisions, although you are married and there's assumptions of your who it should be, no one's going to know to ask those questions. You are dealing with pediatricians. They are not going to be thinking about those pieces. And so how do we help you be your own agency in that, as opposed to expecting those of us here taking care of you to be thoughtful and all that? So I think it's a different way of looking at things than we've looked at it traditionally here. And I am committed to trying to help with that conversation, because what happened with the patient that was given the packet is they came in and his mom said, it looks like it's time to make a decision of whether he's a DNR or not. And I'm like, wait a minute, if this has nothing to do with his care or his cancer or his relapse, but her sense was that we should get his affairs in order because this packet that was handed to them. And I was like, oh goodness, that has misserved us greatly in this moment, right? Again, it's something you have to do. You're an adult being admitted to the hospital, but that packet is not serving us well. And there's no conversation that goes with it. So I was like, even just an introductory saying, as a adult in this hospital, you have the right to this information, but it doesn't, but we have people that can go review it with you and help you understand the decisions that are being asked of you that may not even be relevant for you in this moment.
Yeah, absolutely.
This committee is helping me make lists and lists and lists of things. I just want to thank you all for adding time we meet.
Kind of going back to the like potential benefit of that conversation with the most, as well as everyone is looking forward into this the champion movement and what this working group is looking at is I do think it's important also to note the importance that a MOLST and having advanced care directives can play even in eligibility for hospice if we're thinking about concurrent care where it can get very blurry. You know, you have a patient that has a life-limiting diagnosis, has a rare genetic condition. There's not a lot of prognostication out there that's available. So we're kind of in this weird place of, well, are they really hospice eligible or not? I think the advanced care directives and having a MOLST in place is really what can help facilitate the conversation about what eligibility looks like, because a child that in a family that is really in a place where they would want to have things naturally progress as they're going to, and they're saying we do want a MOLST on file that's going to limit resuscitation in one form or another. I think that also speaks to their goals of care, which then reinforce why hospice is involved and why hospice needs to be involved. Because if they do have a DNR order in place, why wouldn't they also have people that are navigating end of life care? Because they are now in a situation where they are at a increased potential of death because they're not going to necessarily be going to the hospital, even if they have access to concurrent care. So I think that that's an important consideration. It might be something we would consider in some of the recommendations of how to approach certain things, and just again, like lump it into that eligibility criteria to help provide a little bit more reasoning or oomph behind the hospice criteria.
I think those are all really thoughtful points. So do we, Melissa, I don't know if you spoke to Tony about whether we would proceed with the slides. I know she and I did not get to discuss whether she was saying that she would be joining us about 1:30, but I want to be thoughtful of people's time, and we can go ahead and do the slides if you think that would be okay.
Sure.
Okay. Did everyone get a chance to see the slides?
Peter, can you pop them up on the screen? Are you able to?
Yeah, I'll do that right now.
Okay.
Can you guys see that?
Yeah.
Thank you. That's perfect. So today's discussion is, as we always start with our welcome, but it's to kind of talk about our barriers and challenges, a focus on technology, and then a reminder of next steps with a focus on the upcoming calendar of meetings and what we have left in our time together. Next slide. And Melissa, I don't know if you're welcome to go over these, and I can just support the conversation, whatever you choose.
That's fine. I mean, I can talk to it. I think when prepping this, and I've been pulling themes out from the various conversations we've been having, one of the biggest things I think we need to understand and make sure we have a comprehensive list is what are our barriers to providing care, to moving this forward. And it also will lead into what we approach the assembly about, what we want to report out to them. It sort of supports what we're trying to accomplish, as well as, you know, the potential for funding. And so the list here comes from a variety of sources, mainly I think all our conversations, whether individually or collectively. But I wanted to make sure when we have this list in front of us that we're not missing anything, and or if this is incorrect, needs to be course corrected so that we're adequately or accurately representing what everybody's feelings are and everybody's feedback has been based on your experience and expertise. maybe go back to the other slide in terms of barriers. Does anybody, any comments on like the big themes? Are we missing anything on this? And maybe if you want to come back, you know, to either Tony Ann or Dr. Moss or, you know, me, just say, yeah, you got this wrong. Because I don't have the background that all of you have on this. So I wasn't sure if I was pulling in, you know, the most important things. So in terms of nursing staff, I think Eileen has been very articulate in terms of, you know, what she's seeing in the field, the research she's been doing, you know, what we see the major gaps are in terms of serving. Eileen, any comments on, these are big themes, but
I think we could even go bigger.
okay.
So lack of education and awareness, I think even as we were just talking about most, it should be for healthcare providers.
Okay.
So our pediatricians, to know more about the scope of palliative care and concurrent care, what the delineations are, how are we going to describe that, and how are we going to disseminate education to multiple disciplines, right?
Okay.
I know nursing, but I'm sure Dr. Moss would say that pediatricians and specialists would also have gaps, such as MOLS in adolescents or the 5 wishes for children, what's available. And so general information, I think there still is misconceptions about palliative care versus hospice care. As often as it has been clarified, I think it's always good to start with the definitions. But so general education for an awareness for both healthcare providers. Also, we're speaking to education and awareness. I don't think families have that understanding, that clear understanding. It came out, one of the moms that I interviewed talked about a healthcare provider brought up palliative care and she was against it. He said, I don't want that, until the provider spent time with her saying, because the mom assumed it was end of life and that her child was dying. And that was why she was very resistant, until someone sat down and shared with her the definition and all the support and resources that it could offer. She said, now I'm informed, but I wasn't. So I think education and awareness to families. I also wondered about, and Dr. Moss could probably speak to this, our specialists, so beyond the PAC teams, are they aware of when to make referrals? And is that a barrier, timely referrals?
So I think there is the risk of that always, that I do think the younger generation of physicians coming out have had palliative care great education. Like I'm now dealing with some of the medical students I taught, and so they are coming out with more of a thought process that aligns with palliative early intervention and palliative care, which is great. So I do think that there has been a shift to in terms of referrals. The balance of that gets a little challenging when we think about bandwidth, right? Because there are triggers that we can be using, but we avoid triggers because of the bandwidth of our own team and meeting them. So triggers have been a challenge for me personally because I would love to utilize them, and yet our team can't support with the volume that triggers would place. But I do think that I think the specialists understand when to do the referrals. I think the question becomes if the referrals are then placed. Right, they have an understanding of who is a good candidate for. I do think most of the specialists in our institution have an understanding of who is a good candidate. But it's candidacy and translation to referral is not quite. That's where I think there's a little bit of a disconnect.
And also beyond CCMC, do you think? I know you're probably speaking for your own experience, but
it is my own experience. I mean, I think that in most specialists are affiliated with a hospital. And so I think both I think Yale's working on that experience as well, being the two hospitals in the state that would have the specialists that are affiliated most often. So I do think, I mean, education to all levels of staff is needed, right? I literally was on the floor an hour ago dealing with an ortho resident, and I said, "Can you put in a palliative care consult?" And he's like, "What did we do to him in the OR?" And I was like, "No, it's not about what you just did to him in the OR. It's the fact that he has a pretty significant cancer history and is still recovering from, and we've been part of their journey all along. So if someone's going to manage his post-operative pain, it makes sense it would be our team who knows them, right?" But for that ortho resident, there was no awareness of that. So the short answer is I do think people have an awareness. I think that education is crucial to building a greater delivery of the care.
Hey, Barbara, you had a question. I think you raised your hand. You're on mute.
Sorry, I
Okay.
think I have two questions, Melissa. One is actually for Dr. Moss. And when she spoke about the two children's hospitals, Yale and CCMC, is there a role here for all of the other hospitals, though? In DPH's position has always been that a child could present at any emergency department for care in any hospital in Connecticut and should be able to receive, appropriate and adequate services. So as I think broader, and again, not in the initial work, but is there a bigger scope to support all of the other hospitals that may be presented with children and what they need? Or are there, and again, this is where I'll rely on the experts here, or are there quick referrals made to get that child to a pediatric center?
So I think there's definitely quick referral processes, right? So we receive children from outside hospitals every single day that come in based on acuity of care and or complexity of care. And so, or because their home center is here and they've gone to that institution for stabilization and then are brought to us. So the answer to the question is I think we are often involved with most of the outside hospitals. Do I think that ideally in the pie of the sky tiered level approach to pediatric palliative care, should we be reaching out to all hospital systems? I think the answer is absolutely yes. When I think about the priorities, that might not be my number one. That might not be the number of priority. And some of it is the acute management of what do you do when a child comes into your emergency room after a car accident, right? The more acute injuries that can occur. And if you are they're not going to transfer a patient here that is not able to be revived in any capacity. So then what resources do you have in those hospitals for those moments? But that wouldn't involve a full MOLST conversation, right? Those wouldn't be the cases where the child has arrived dead on arrival. And so it might be very different. But I do think that education to all hospitals and should have the same resources and opportunity to provide the same care is fair.
And then my second question, Melissa, is related to the certification and licensure. Could you expand a little bit more? I'm not sure I understand totally what the goal is there. Because currently the certifications are done, the ones that we look at and that we looked at for the palliative care report were related to credentialing centers. DPH is not a credentialing center. So I just want to make sure that we're fulfilling the requirements of the goal or the mission there.
Well, this goes to my baseline ignorance of what your group was working on. So I think there was a discussion that you would be coming up with some baseline certifications. I could think the bigger question is, how does that spread out across various facilities? What type of requirements would we ask people to have? So it's a little amorphous, but it is something I think early on we talked about. We needed to have at least a minimum standard for dedicated providers, whatever that means. And I realize it's a little bit wishy-washy, but some concept of certification and licensure, so that we could. I think it's setting a target for what best in class looks like, but also, if for example, this referral process, if the facility doesn't know where to go, well, we've got, we've defined, here are the following 3 different organizations, facilities that can do what we're asking them to do. So,
okay, I think what I would ask then is, because I marvel at the work that the Connecticut Palliative Care Advisory Council is doing. Rather than say Connecticut DPH, I would like to give them the recognition for the work that they are doing and the value that they bring to this. And then maybe there can be synergy with, maybe this is a conversation that I can bring to Karen Mulvihill, who is the chair, as an agenda item to talk about, is this work that this group can help with. The mission is focused on palliative care, and here's a role where groups can work together.
Okay. Thank you.
Thank you.
I'll look to you for clarification on wording and all that stuff. So
Okay,
thank you.
I appreciate that.
Sure. I think we've had some conversations about kind of geographic access, but it sounds like there is a referral process in place, but we may not have as many facilities across the state that either have a dedicated approach to serving pediatrics or have enough breadth to do that. So that's one of the things to take in consideration, I think, as we build things out. We know that, certainly the Connecticut Children's Hospital can serve these needs, but if you go farther east in the state, are there facilities that have the same capacity? And if not, how do we help families in those areas and the facilities that are receiving these children to get to different places so that they can be served in the way they need to be served for their illness?
There's a hand raised ahead of me, and then I will say something. Go ahead.
Jessica.
I just kind of looking through, I love this diagram though. I just want to say how visually pleasing this is to have it all, not only the colors, but really just honing in on those bigger themes and being able to loop those together. So I very much appreciate this visual representation.
It's PowerPoint smart art, if you wanted to.
Oh my gosh, thank goodness for PowerPoint. But I think when I look through this, I have a couple of just generalized thoughts, which one is that some of these things are works in progress that last years and years and years. That even with well-defined regulation, well-defined support in place, are going to be continuous areas for improvement or growth, especially when it does come to that education standpoint and growing not only the awareness of what can be offered to those providers, but even just offering that training certification. And we're in a very great place, I think, nationally with the coalitions that have come forward, with all of the different educational offerings that are there. People that have been in this work for decades are getting the opportunity to learn new things by connecting with colleagues through Zooms and all those things. So I do think some of these things are not necessarily barriers that can be solved immediately. It is very much a growth over time. But the other aspect that I really see in a lot of these as well is that there could be a lot of benefit of really putting together that hopeful end-to-end process where we start at recognition of a potential hospice concurrent care patient. How do we identify that patient, into the steps of how do we treat that patient in the hospital or stabilize them, have the conversation about MOLST or a referral, and then much to the point that was just brought up, like who are the providers that are there? And I think that goes into maybe like a caveated point as well, that some of these barriers are things that across the country, everybody is very much still fighting against, such as resources for more rural areas and the accessibility of care. Regardless if there's a trained pediatric professional with that hospice, there may not be a hospice that can really serve that area. And so they have limited access even for a 90-year-old that's needing extra support. So how do we help educate families on their rights and their ability to access services as well, just being by nature of where they live? So those were my immediate thoughts, kind of all quantified together. But I really love how this is all laid out and how it even goes from that more like particular, really the micro to the macro, right? And I think that's just a really important aspect of what we're doing.
And Jessica, I love your concept of end-to-end process, because I think that's a visual we can all embrace. And I think it'll be very easy visually to show what happens, upon diagnosis and taking it through the process, handoffs, providers, information, recommendations, referrals. And that would be a terrific way just to show how we envision, care for a child, and it personalizes it too. And I think that's one of the things that's been raised a number of times is showing personal example, not a person, but an example of a child with X disease condition, and how we anticipate, hand holding and taking care of that child and their family.
Absolutely, absolutely. And I think it helps also provide that jumping off education point for those that aren't in healthcare, that aren't seeing these processes happen every day, that may not understand the concept of like even how consults work and how does one get a palliative care consult and how does that impact their care? Dr. Moss, like what you were saying, well, are we there yet? We really need palliative involved. Well, let's talk about what a palliative consult is and the full umbrella of support that can be offered. So I think that it's just a great tool to be able to use, especially thinking that there will be non-healthcare people that are taking a look at this and trying to understand the concept.
And here's a question. Does anybody on the team have an example of something like that we could borrow from? I mean, the best, most sincerest form of flattery is plagiarism, I guess, to misquote something. But if anybody has any examples of that, that would be terrific to look at. And so we could build something out visually.
I do.
Yay. We thought you did.
I'm happy to share and to like tweak some things and see if we can have a good jumping off point.
I think
Fabulous.
I probably have a couple of cases too that we could. I apologize for being late. But I had a great stand-in in my chair.
They said your hair got much longer.
Yes, overnight. We have a couple of cases that we can probably follow that, I know of a couple that really had difficult, some barriers or whatever, but we can definitely follow some of those cases. And I apologize that I was late and I don't know, it looks like you've covered like most, like the important kind of that thing there. I did want to say though, I feel like we're also need to look at how other states are actually doing the criteria for pediatric hospice or pediatric and palliative care, how they've changed either a bill or the criteria, like in other words, saying this child is eligible because we know that either they are not going to live to adulthood or they're going to die if the disease took its natural course, they will die in 1 year, which I think is better than 6 months. But I also think we know with concurrent care, there's the opportunity that this kid could live for years, but we also know they're probably not going to become adults. They should be entitled to this benefit.
Mhm.
And so I think there's a couple of things from that perspective. And Elle, maybe you could maybe be helpful on that. If you could, I don't even know what bills are out there or, certain things that could be amended that could help us take care of more kids. But that would be great if you could help in that area. And I know, Barbara, already we're, thinking about the regulations for pediatric hospice and palliative care. That's another thing. I think in a couple of years to come, what nursing program curriculum should look like and what rotation should look like and all of that, I think that can be determined. But how do we, and I think what the recommendation is that we have to show in February is if these things happen, we could at least take care of kids once we have nurses in place. But until then, we're not gonna solve, I think, the staffing issue right now. But I think I'd like to see if we were to change a bill or look at criteria, how that could help us take care of more kids.
Eileen, you had a hand raised.
I have two comments. One is, Tony, and did you find the articles I sent regarding some of the states, how they delineated the categories with palliative care and concurrent care, the delineations? There were specifics. I think Michigan had a model. Did you find them helpful? Should I send them to Elle?
Why am I not remembering those?
You wrote back to me saying you found them interesting, so I can resend them to the group. It might be helpful.
Oh, yeah, the one with the different states. That's where I got that's where I got a lot of the information from. I'm like, wait, what did Eileen send me? Yes, that's where I got a lot of the information from. And that was where I believe it's Michigan that says if children are not going to reach adulthood, they're considered terminal. And that's how they're treating their kids. That's where the information, I think it would be great if Elle could have that information and we could look at things like that. That would be great. And thank you for those.
Yes, of course. And happy to send it to the whole group.
Yeah.
Yeah, that would be great.
Yeah.
And then secondly, kind of just going back to the PowerPoint, I don't want to lose sight of not only awareness of available resources, but the resources that we may lack. I am hearing from parents that respite care is, or their understanding of respite care is not available. And I know, Tony, and you have said otherwise, but I think
Well,
we need to clarify how families can receive respite care.
well, they have to be on hospice to receive respite care at regional hospice. That's the thing. There are some of those states, and like after Jessica and I met with Jonathan Cotter and we spoke about respite homes that are in Arizona or other places which are totally free, totally supported by fundraising and things like that. That's a house that anyone can go to for respite. They don't have to be on hospice. You know, they can just go there for respite. For us, we do respite for our peds, but they're on hospice. That's how we provide the service.
So when we're looking at barriers or challenges, do we need to be looking at or stating the models? Does this need some work? Could it be, a patient is receiving only palliative care? How do they have access to respite?
Mm-hmm. Right.
Do we have a sense as to maybe what sort of a comprehensive list of what parents ask us? And I think we probably know a lot of it, and we've probably talked about it, but do we have kind of a single source of here's all the things we're hearing from parents? And some of this probably will map up against the things that we're proposing, but I think that gets to the personalization of what we're trying to represent and articulate.
I don't think we don't have a specific list. We could put, I mean, Eileen's research will probably have a specific list, but we don't have one that we look to. I mean, I could anecdotally tell you the top 10 things I hear most commonly from families.
Maybe it'd be helpful if we did have a single list. Eileen, if you have one, and maybe just share it with the group, and we can expand it as if we don't see something on that list that you've heard about.
Sure, I can do that.
Okay.
I just want to address that concept of, I think that the concept of respite care is probably beyond the scope of what we can manage in the time we have, in terms of it really is so philanthropically based. If you look at the George Mark House that I was so inspired by as a resident and spent some time there with Dr. Beach when she was, when it was really up and coming, it is an incredible opportunity, but was 100% philanthropic supported, right? And then there was a couple grants, if I'm remembering correctly, a couple grants are awarded, but these are small seed grants that maybe the state helped with, but they weren't sustainable funding. And so, like all philanthropic organizations, they hit a wall where they almost were not going to be able to continue forward. And so it really is, unfortunately, respite care is not a reimbursable need, right? Doesn't mean it's not the greatest need, but it is not a reimbursable need in most situations. And in most in care environments, it's certainly not a reimbursable need. And so that becomes part of the challenge, and hence why people like their shift nursing, because when they have shift nursing, go to the grocery store, so they have what can, what kitty respite care for patients when their child has a nurse that comes in the afternoons to do stuff, then the parents utilize that as opportunities to do other things. And so that's why shift nursing might be more appealing than skilled-based nursing that palliative care or hospice can provide, because you don't get the same concept of respite. Does that make sense? Like, I love the idea of tackling respite. I just think it's probably bigger than what we can handle right now, because it comes with a great deal of funding necessity and sustainable funding necessity.
Yeah.
And I know there are several payer sources that provide a respite benefit as part of the private duty nursing. So they'll be entitled to 420 respite hours within the calendar year, and they can use those hours in any way that they please. It could be to fill an extra shift, or if they're coming home from the hospital, they're needing extra support for 24 hours. They can go into that bank, but they can also use that as a respite in the home where they're not having to transfer out. But I don't think that that's always the most accessible option, because it is dependent on the approval private duty nursing, its approval of respite hours being added to that private duty nursing, and honestly the family being able to navigate that, and them knowing the right questions to ask, and feeling like they have full information or informed consent to what that looks like.
So
And if we wanted to go one step further, right, and we say, okay, they have these hours through, through their Medicaid or Husky, let's just say, I can't even take them here because of the license. I couldn't even say, okay, we'll give you 24 hours. You can come here and have respite. My license doesn't allow that. So they would have to be, because that's an idea too. I would love to be able to offer respite here. But my license says the patient has to be on hospice. So those are things too that we could always provide, but again.
I think also, I'm sorry.
No, go ahead.
I think what we're considering, we have to think about what we're doing right now is we're proposing something, and it's going to be a phased approach, and this is a multi-year approach. So respite might be further on down the line that we could accomplish, right? And it should not fall off our list. It's just something that we may not be able to get done quickly, but certainly we should be looking at that.
Agreed. And I wasn't talking about a separate house at this time, but more of what Jessica was saying. Are payers able to offer a certain allocate a certain number of hours that can be made available to families? That I would love to see that woven in here somewhere. Maybe it's the last bucket to include.
Okay.
I can't speak to Husky, but I do know commercial insurance, that's pretty widely utilized as a benefit.
I think it is. I think that the limitations in nursing in the state of Connecticut for shift nursing allows it not to be used for true respite, if that makes sense. I think they're being used for other things. I think you're right. There is an allocation with private insurance. I'd have to look at Husky to see what the hour amount allotted was, but I just don't know that it's being used for in the need that Eileen is speaking to, which is parents stating we need respite. I actually don't think those hours that we call respite are actually doing that provision.
Yeah.
And that's a bigger, obviously that is a much more global issue than what we're talking about here. But I do think that is something we have heard forever, is respite, just, opportunities for in home or out of home, like going, like they're, traditionally, and I can't speak to if they still do, the George Mark House used to house kids. And so parents would take the other kids to a trip that child couldn't go to, and that child would go on vacation there and have activities and other things. And they were used to be able to provide that. I don't know if that is still something that happens anymore, but that was respite to the best degree.
Yeah.
Tony, and I only had a couple more things I just wanted to recap with the group, but I don't know what else, if we want to talk about this further.
I'm good.
Okay. Because we only have a couple minutes left, so I didn't want to take up people's time beyond that. Peter, if you can just go to the next slide, but just a reminder, we will be having the person from the Katie Beckett waiver come into the group. We've floated some dates with them, and so they will be invited back. The other thing, I think we had talked about having someone from Massachusetts either talk to us as a group or individually. And so just wanted to put that on our list of to-dos. Also think about who we want to share information with for our next advisory group meeting, what speaker. And we've kind of kept those advisory group meetings to kind of top level thought leadership, just to keep, the information top of mind with the larger group. So if people have ideas about that. I went on family visit last week, but dealt with elderly family members and things like that. But I also talked to a younger family member who's in the IT space, and I was kind of sharing some things we're doing and talking about aggregation and curation solutions for families. And he's like, "Hey, have you heard about this one?" He goes, "And there's a million of them out there that maybe you can consider." But and this is just kind of future thinking as we think about education, having some sort of online presence. It might be something we need to build into our overall education. Obviously we have paper, we have in-person sharing, we might have case managers who facilitate conversations. Anybody in the healthcare space would be communicating the parameters of what we've accomplished, the program we've defined. But this is another venue to communicate and give parents a tool. And this is just an example. This is not necessarily something we have to do, but it's an example of an online solution. It's AI search and chat, where you would have a functionality. They would go into it would aggregate all the sources of information that we deem to be the most appropriate. And if you look, I went from left to right, like the little image, and the question I put in, and I just looked up childhood leukemia and asked the question. And then it gave you the next tier over says searching. It gave you all the list of areas, NIH, Seattle Children's. I mean, it's, some probably reputable sources. That may not be the things we want to access, but we might want to have an aggregator and identify the prominent sources. And then there would be, additional, deep dive publications, things like that. And then it comes up with images of T-cell acute lymphoblastic leukemia. So, just something like this could be something we might want to consider as we build out our education process. And I think, Tony Ann, you had made a comment before education. This is going to be another working effort to create education. It's not only it's what we want to say, but customizing the information for who we need to deliver and then how. And there's no single way that we would be doing this, but there's going to be a lot of different audiences. For example, for medical practitioners, we could get rather technical in terms of the information because of their referential information. For families, you want to have something a little bit more directional and guided and supportive so that they have information about what's available to them. So, and then there's associations and organizations that we will want to cross-fertilize our presence and so on and so forth. So there's a lot of different ways to do it, but I just wanted to show you a quick little look at AI, how AI might be a good tool for us to consider as we go forward. So
Yes, I completely agree. And that's like when we think of where does everyone go to get their information? What does it look like? And what kind of information is it? And that's a whole other animal to tackle, right? As part of all of this. So that's a really good point.
Yeah. So I think we're in good shape so far with everything. We still have a lot of open questions, but I think we're making progress. I think we just need to find out, trying to find out to know what we don't know. There are more venues to pursue, I think.
True.
and we're never going to be done. That's the point. It's always going to be a work in progress, right?
Yes, ma'am.
So Tony, and the one thing that we did discuss was the idea of a meeting in person here that I'm going to look to set up, and maybe the first meeting in January. So there's a little bit more time for the report to make
I would
edits.
love that.
Try and do an afternoon meeting on the 7th, convert it to a meeting here. I'm going to look at office space and send out that up to you guys.
I would love that. I love being in person.
Yeah, and Jessica's going to walk because we can't fly and we can't, so.
Oh, I took the train though. I'm never not taking a train anywhere ever again. That was the most delightful experience ever. Just to be able to work for 6 hours and like be surrounded by fall, and
Yeah.
it was great.
Oh,
Yeah, it's honestly, and when we go to New York City, I'm always like, there's no other way to do this. It's so pretty and sweet. And
Yeah, it was great. It was wonderful. Much better than sitting in traffic and much better than TSA.
yeah,
right.
pray for me next week, friends. Pray for me.
Yes.
All right. Well, then I'll be in touch with that as we come up. I'll be in touch with that date. Is there
Okay.
anyone else that has anything to add before we adjourn today?
Elle, I just want to make sure you knew, Elle, if you're going to be looking to states, DC Medicaid just released a statement on coverage for concurrent care and hospice. So they just released that statement, I think about 3 weeks ago or about a month ago.
Yes,
I
it's
think
in
sorry.
to it. Thank you. Yeah, I will compile and I'll make sure if I find anything, I will send it your way.
Fantastic.
Perfect. And thank you all again. This is, it's such an honor to be like on this with all of you and to do this amazing work. So thank you again, everyone.